Hello everyone, this is Dr. Richard Madonna, Professor and Chairman of the Department of Clinical Education at the SUNY College of Optometry. My email is available to you and it will be also available at the end of the program in case you wish to contact me about the content of the program. I'd like to thank the organizers for putting together a wonderful CEwire 2019 and for inviting me. I appreciate the theme of the conference, the eye and body, and when they asked me to speak, I thought it would be a natural to speak about systemic diseases and glaucoma. So let's do it. There are my disclosures. I don't believe any will be germane to today's discussion. For nearly 100 years, we've heard this statement: a glaucomatous eye is a sick eye in a sick body. I certainly heard that during my training. I assume we still utilize this terminology or this statement, and it makes sense. The eye is part of the body, so we have a chronic disease of the eye, which would very likely be associated with other systemic diseases. But is it? Real question is, do we see correlations between systemic diseases and glaucoma, or is there actual causality? And I'd like to investigate some of that today. So do systemic diseases play a role in the pathogenesis of glaucoma? So we'll look at a number of areas. This is a huge topic. I'm going to spend great majority of the time on blood pressure because I think it's the one that has clearly been shown to be causal, and I think we should understand that relationship well, and then we'll look at a number of other areas. So again, let's start with blood pressure. Here is a section of the optic nerve looking at the blood supply to the nerve. We know that the majority of blood supply to the optic nerve is via the short posterior ciliary arteries, which are arranged in a circle around the optic nerve, the so-called circle of Zinn-Haller. We also get some contribution from the peel arteries and branches of the central retinal artery, but essentially we're talking about blood supply from the short posterior ciliary artery. If we look at the so-called ocular perfusion pressure, or the pressure that blood is driven into the eye, into the optic nerve, we can look at it as a very simple formula. The ocular perfusion pressure is the blood pressure minus the intraocular pressure. And blood pressure can be measured in the three ways we can look at blood pressure: mean arterial blood pressure, diastolic blood pressure, or systolic blood pressure. The one that's been studied the most, the diastolic perfusion pressure, the DOPP, is the diastolic blood pressure minus the IOP. So if the diastolic blood pressure is 70 and the intraocular pressure is 20, then the diastolic perfusion pressure would be 50. We do have to keep in mind, though, that the blood supply to the optic nerve is auto-regulated. In other words, to maintain homeostasis, the tissue itself has the ability to make changes in its perfusion such that if the perfusion pressure gets too low, then the blood vessels locally will dilate to allow more blood to get to the tissue, and conversely, if the perfusion pressure gets too high, it will do the opposite. Many tissues in the body can do this, but the heart, the kidney, and the brain and eye have a special ability to auto-regulate. So that's very important to remember, because auto-regulation tends to occur in a very small range of perfusion pressures, maybe 20 or 25 millimeters. So if we get to a condition where, let's say in systemic hypertension, the autoregulatory curve starts to trend upward because the blood pressure is higher. In situations where perfusion pressure goes down, the tissue may not be able to respond to that. And that's something that we see in glaucoma, as we shall see shortly. So what about the link between systemic hypertension and glaucoma? This is a question my patients ask me all the time. Doctor, I have high blood pressure. Is that why my eye pressure is high? Well, in 2005, the Beaver Dam Eye Study looked at this relationship, and they showed that the relationship between intraocular pressure and blood pressure is, there is a relationship, but it is a small one, 0.21 millimeter increase in intraocular pressure per 10 millimeter increase in systolic blood pressure. So you'd have to drive up the systolic blood pressure 50 millimeters to get a 1 millimeter increase in intraocular pressure. The relationship is a bit stronger with diastolic pressure at 0.43. Interestingly, though, in that study, they showed that if you decrease systolic or diastolic blood pressure greater than 10 millimeters and sustain it, you get a significant reduction of intraocular pressure, which could be important to us. But we have to be careful with that, as we shall see shortly. Same year, British General Practitioner database showed that patients with glaucoma had a 23 to 36%, or were 23 to 36% more likely to have systemic hypertension than patients without glaucoma. So there is definitely a relationship in place. Now we're going to look at this paper 3 different times. This comes from the University of Michigan, Joshua Stein. The last author on this paper is an ophthalmologist and epidemiologist, and his group tends to look at insurance databases and look at diagnoses and then make links between diagnoses. Now you might say, well, geez, ICD-10 codes are not all that accurate. The coding may not be accurate, but this group tends to look at N's of millions of patients, which I think takes some of the slop out of the data. So there's an adjusted hazard ratio for the components of metabolic syndrome, hypertension, diabetes, hyperlipidemia, and central obesity. And we see that in this group, there was a 17% increase in the prevalence of open-angle glaucoma in patients who had hypertension alone. We are going to return to this paper, as I say, as we go forward. So why then is hypertension a risk factor for glaucoma? Well, maybe the obvious: damage to the small blood vessels feeding the optic nerve, causing poorer blood flow to the optic nerve, the so-called vascular theory of glaucoma. That makes some sense. Perhaps it's increased ciliary body perfusion causing increased aqueous production. That could be the case, but the ciliary body blood supply tends to be nicely autoregulated. It may be due to increased episcleral venous pressure. The episcleral veins, of course, are downstream from the trabecular outflow, and increased episcleral venous pressure causes the intraocular pressure to go up, and we see that when we lie down, as we will discuss. But the biggest reason may be not the hypertension itself, but the association with hypotension, either being over-medicated with blood pressure medications, taking them at the wrong time, perhaps in the evening or at night, or dysautoregulation caused by chronic hypertension that I alluded to before, a shifting of the autoregulatory curve toward higher pressures, making one more susceptible to lower blood pressure. So this is the well-known habitual intraocular pressure, 24-hour intraocular pressure curve. We now know well that in the majority of people, the intraocular pressure is highest during the nighttime period, and particularly higher when we are supine, and that's mainly because of the changes in fluid dynamics in the body and changes in episcleral venous pressure. We also know that the pressure during the waking hours is highest upon awakening, and that's been known for a very, very long period of time. What if we then superimpose the blood pressure curve? We know that in most of us, the blood pressure goes down during the nighttime period and goes down precipitously in certain people who we can call dippers, and we see that here. We can also place the systolic pressure curve in, and there's just showing the difference between the two. Suffice it to say then, if we think back to our ocular perfusion pressure equation, we know that if the intraocular pressure goes up and the blood pressure goes down, then perfusion pressure will go down. And for those who are dippers or those who have a precipitous increase in intraocular pressure during the night, this may overcome a threshold where the optic nerve could be damaged because of lower perfusion pressure. And this is a very, very important relationship to remember. So is there a link between ocular perfusion pressure and glaucoma risk? Well, there's numerous cross-sectional studies that show us that there is. Baltimore Eye Survey, African Americans and Caucasians showed this relationship. Egna Newmark in Italy, Caucasian patients. The Los Angeles Latino Eye Study, Latino, mostly Mexican patients in Los Angeles. And the Proyecto Vera study in Arizona, Hispanic patients all showed this relationship between lower diastolic perfusion pressure and primary open-angle glaucoma. So we certainly have evidence. And this just shows the relationship of the diastolic perfusion pressure and glaucoma prevalence in this group. And you'll notice that there's an inflection point here in all these studies, around 50 or so millimeters of mercury. So we think that if the diastolic perfusion pressure gets on average below 50, we start to see a greater incidence or prevalence, I should say, of glaucoma. Now, what about 24-hour IOP and blood pressure? Well, Costa looked at this back in 2010, and what he found was, and this is an interesting one, that in patients with primary open-angle glaucoma, although they had higher systolic perfusion pressure during the morning, they actually had lower diastolic perfusion pressures during the nighttime period. So thinking back to the curve that we talked about before, this could place tremendous strain on the system and cause damage to the optic nerve because of reduced perfusion. Charlson et al. In 2014 looked at 48-hour ambulatory blood pressure measurements in patients with normal tension glaucoma. On the left, you have a progressing patient, and on the right, a non-progressing patient. The dotted line is the average mean arterial pressure during the waking hours, and this line here, the continuous line, shows the mean arterial pressure during the sleep hours. And what you can see is, in the progressing patient, the perfusion pressure is down below the average during the daytime hours. Yet for the non-progressing patient, it is at least equal to, but in most cases, in this case, above that average. So it shows the relationship between progression and a drop in mean arterial blood pressure during the nighttime period. So if we look at this as optometrists, how can we impact this relationship? Well, we have to be aware of it. We need to measure blood pressure so we can find those patients not just with high blood pressure, but those with low blood pressure. We need to talk with PCPs in our patients and ensure that our at-risk patients are not taking their blood pressure meds at bedtime. Now, I talk to my patients about this all the time, but I always take their primary care doctor into account. I don't just tell them willy-nilly to start taking their blood pressure meds in the morning. I like to form that relationship with the PCP. So working with PCPs to ensure that ocular perfusion pressure is taken into account in glaucoma patients is important, and it helps foster that interprofessional relationship. We also want to prescribe glaucoma therapies that work during the nighttime period. Prostaglandin analogs, carbonic anhydrase inhibitors, Rho kinase inhibitors, SLT, surgery, all work reasonably well during the nighttime period as opposed to alpha agonists and beta blockers because they work on the autonomic nervous system. So they work less or basically not at all during the nighttime period. And then in the future, perhaps we'll be measuring nighttime IOP. We now have the iCare home tonometer, and although that can't be used in the supine position, it can certainly take intraocular pressures during the nighttime if the patient is sitting up. And perhaps in the future we'll have the triggerfish available to us, which can measure ocular volume changes correlated with IOP during the nighttime period, or perhaps other measurers of intraocular pressure that allow us a 24-hour pressure. Our next topic is cardiovascular disease. Now, this is a monster topic. There are so many different types of cardiovascular diseases, so I just whittled it down to a couple. Let's talk first about dyslipoproteinemia, high cholesterol levels, and so forth. Actually, there's no good evidence linking dyslipoproteinemia with glaucoma, and in fact, statin drugs actually appear to have a protective effect in the relationship between high cholesterol and glaucoma. I'll show you some data in a moment. We believe that the statin drugs have an antioxidant or neuroprotective effect. They may lower IOP a little bit too as well, but that's not the big reason. So statin drugs actually appear to have a protective effect. So back to the paper we looked at before, the Stein paper, and looking at metabolic.